In the adult stroke world, I don't think anything is more challenging than distinguishing intracranial arteriopathies. Atherosclerotic disease being all too common, even if you have a young patient with a little diabetes and hypertension, some intracranial segmental narrowing could just be intracranial athero. Or if you have an older patient with well-controlled dyslipidemia and vascular irregularities, that could also be athero. But in each of these patients, there could be something even more sinister. Could your younger patient have moya-moya or Behçet's? Could your older patient have giant cell arteritis or VZV vasculitis? What I'm saying is that even if the pattern is classic for atherosclerotic disease, meaning the patient has calcified and non-calcified plaque in multiple arterial segments and the narrowing is near vessel bifurcations, you've always got to wonder, is there something more to this patient that I could be missing? Even more challenging is the situation where you have a patient who has severe headaches, new stroke, and then they have these vessel irregularities. Sure, stroke can give you a headache. Maybe 20% of patients will report some sort of head discomfort. And sure, intracranial atherosclerosis is common in patients with stroke, 20 to 30% of all cases. But could these clues be suggestive of a more serious underlying condition? For most of the listeners out there, I don't have to tell you that it's of vital importance to be able to distinguish RCVS from primary angiitis of the CNS early on, because both conditions can cause rapid accumulation of new infarcts, and yet the treatments are vastly different. Not surprisingly, treating one condition instead of the other may actually result in neurologic worsening. According to one cohort of 162 patients with RCVS, those who were treated with corticosteroids more frequently developed clinical and radiographic worsening. So don't do that. In this week's installment of BrainWaves, a podcast about neurology and medicine and all the fascinating science and history that come with it, we'll be reviewing these and other interesting features that differentiate RCVS from primary angiitis of the CNS, at least according to your textbooks and the literature. And then we'll conclude with some of the dilemmas that we're left with in real-world scenarios. I'm Jim Siegler. Don't go anywhere. I'm joined in Studio 3 this week by my friend and co-fellow in vascular neurology at the Hospital at the University of Pennsylvania, Jesse Thon.
This is Jesse Thon.
In addition to serving as a vascular neurology fellow, Dr. Thon has previously completed a fellowship in neuroimmunology.
I also did a neuroimmunology fellowship at Mass General Hospital and have a particular interest in the overlap between vascular and autoimmune disorders.
So yeah, of course I'm going to chat with him about the overlap between RCVS and primary angiitis of the central nervous system. Let's get right into it. So why don't we start with the clinical history? I opened up our interview by asking Dr. Thon about the clinical history. What is it that a patient would tell you that might raise your suspicion for RCVS versus primary CNS angiitis?
Well, far and away the most common symptom patients with RCVS have is headache. And it's not just any headache. It's a thunderclap headache, meaning onset to peak intensity within seconds, worst headache of life.
This can be with or without any focal neurological deficit, and it's not unusual for a patient to present with nothing but the headache.
About 50 or more percent of patients with RCVS actually just have an isolated thunderclap headache, so they don't necessarily have to have focal deficit.
Usually, the patient's going to be young or middle-aged, 20 to 50 years old. They're going to look very uncomfortable when the headache happens. They may be nauseated or vomiting.
That's a symptom you would definitely expect with RCVS.
And over a period of minutes to hours, the headache often goes away.
Also, female gender is associated with RCVS, and a history of migraines, interestingly, is also more common in patients with RCVS.
How does it happen? What do we think is the underlying mechanism for RCVS?
Yeah, so the pathophysiology of RCVS is unknown. We think it has something to do with the same underlying pathology of PRES. They have some similar features, reversible edema in some cases, and even reversible vasculopathy in some cases, or eclampsia. We see that in postpartum patients have a higher incidence of RCVS, but we're not really sure of the mechanism. Now, the reason why headache is such a prominent feature is probably actually just because of the sensory receptors in the blood vessels that are being affected. So the trigeminal afferents and also the dorsal roots of C2. And that might suggest also the location of headaches that patients get with RCVS. So holocephalic headache is the most common with RCVS. Patients can also get headaches just in the vertex or the occiput, which again implicates the C2 fibers.
So what are the diagnostic criteria for RCVS? I mean, it is a clinical diagnosis, and like Dr. Thon is alluding to, probably a very heterogeneous condition with multiple triggers that converge into a single pathophysiologic syndrome. So how do we diagnose it? There's no blood test for RCVS, nor is there a perfectly sensitive radiographic biomarker. What we do have are a set of clinical criteria. The International Headache Society has published a modification of the original Calabrese criteria for RCVS, and they have specified the following. The patient should experience severe headache. It should be a uniphasic disease course, without any new symptoms after 1 month from symptom onset. There should be multifocal cerebral arterial narrowing with reversibility by 12 weeks, a normal or at least a near normal CSF, and exclusion of other neurologic conditions like aneurysm rupture and primary angiitis of the CNS. And here's what Dr. Thon had to say about the CSF testing.
So if someone has a classic picture for RCVS, I don't think it's mandatory that you get a lumbar puncture. But if there is some diagnostic uncertainty, the CSF profile in RCVS is typically normal. And in primary CNS angiitis, although not always abnormal, and actually a minority of patients actually have pleocytosis, if it is present, then that would pretty much exclude RCVS.
Again, which is what the International Headache Society has defined for RCVS. The one caveat I might add is that 30 to 50% of patients with RCVS may have subarachnoid blood on their initial head CT, which is usually cortical, so atypical for an intracranial aneurysm rupture. But because there is subarachnoid blood, the CSF testing may be abnormal due to the bleeding. Now let's talk more about the headache though, because it's pretty unique. Like Dr. Thon said, the headache in RCVS is severe, and it peaks in intensity within seconds. Like a ruptured aneurysm, or with spontaneous intracranial hypotension, or in some cases of cerebral venous sinus thrombosis. But unlike these other causes of thunderclap headache, the headaches of RCVS frequently recur. Usually a handful of times before the diagnosis is made.
So another association with RCVS is triggers.
These triggers can be as nonspecific as head trauma,
exercise,
pregnancy,
stressful or intensely emotional situations,
or even sexual intercourse.
And then there's also medication and drug triggers.
Usually sympathomimetic or serotonergic drugs.
Things like cocaine, amphetamines, THC has even been associated with RCVS.
And also over-the-counter drugs, neurostimulants, caffeine for crying out loud.
Really anything vasoactive.
Not to mention the drugs that we commonly use to treat severe headaches, drugs like ergots, triptans, and Fioricet.
But also SSRIs for depression, or even over-the-counter nasal decongestants or cough syrup. The dextromethorphan and Robitussin has been linked with RCVS as well.
So in your history for a patient who has a thunderclap headache, regardless of what the imaging looks like, a thorough review of the patient's med list and supplement use history and screening for any substances of abuse are going to be key here. And then CNS angiitis has a whole different demographic and profile.
Yeah, that's right. So patients with RCVS tend to be younger than those with primary angiitis of the central nervous system. And then headache is actually a feature of both, but the type of headache is different. So thunderclap headaches are much more common in RCVS, whereas in someone with primary angiitis of the central nervous system, you get more of a history of indolent, more long-standing headaches.
Paralleling the headache course that's seen in primary angiitis, the other neurologic features are also insidious and progressive. Encephalopathy or focal deficits are characteristic findings of primary angiitis, but not necessarily in RCVS.
So at the time of presentation, seizures are actually more common with primary angiitis of the central nervous system, and also focal neurologic deficits in general are more common.
And systemically, you might think that since primary angiitis of the central nervous system is a vasculitis, there are going to be more B-type symptoms. But that's not exactly the case. Fevers, weight loss, night sweats, these symptoms are reported in fewer than 20% of patients with primary angiitis, and inflammatory markers like the ESR and CRP are abnormal in only a quarter of patients. If I were a betting man, I would say there's not much to hang my hat on just yet. Both RCVS and primary angiitis of the central nervous system can present with headaches. They have intracranial vessel irregularities, focal deficits, strokes, even subarachnoid or intracranial hemorrhages. Nothing is particularly pathognomonic yet, but if you had to bet, based on which condition was more common, you'll have to go with RCVS.
Yeah, and actually the incidence of RCVS is unknown. There haven't been good epidemiologic studies that have clarified that.
If you look at some of the single-center observational studies that are published on RCVS, investigators report an incidence rate somewhere on par with 10 or 20 cases a year.
So in clinical practice, we actually see it pretty commonly. So definitely much more common than primary CNS Angiitis,
which we've estimated to affect 500 or 600 patients in the US every year. So to recap, RCVS is more common than primary angiitis of the central nervous system, but we're limited by a lack of great observational epidemiological data. Whether underreported in clinical studies or it's a misdiagnosis is hard for us to know, but at least we've made efforts to guide clinicians toward the diagnosis of RCVS. As an example, in February of this year, a team of neurologists at Massachusetts General Hospital sought to develop a score that you could use to predict whether a patient had RCVS as opposed to another large or medium vessel arteriopathy. Granted, there is no gold standard for the diagnosis of RCVS like we mentioned earlier, and therefore you might argue that the elements of this score that are used to predict RCVS are actually just the features that we typically ascribe to the syndrome. But still, it's a useful tool.
A new kind of diagnostic scoring system was just published in Journal of Neurology, you might have seen.
And with most things in stroke, it's got a fun mnemonic, the RCVS2 score. Dr. Thon and I talked about this briefly. The R stood for recurrent or single thunderclap headache, the most important and the strongest of all the predictors in the score. C for internal carotid artery involvement.
If the patient had intracranial carotid involvement, that was actually a point in favor of primary CNS vasculitis as opposed to RCVS.
Then you have V for vasoconstrictive trigger, and S can give you 2 points, 1 point for female sex and 1 for subarachnoid hemorrhage. RCVS occurs at a 2-to-1 ratio of women to men, and primary angiitis is a 2-to-1 ratio of men to women. Ultimately, with the higher RCVS2 score, your sensitivity and specificity for predicting RCVS can be greater than 90%. And speaking of carotid artery involvement and subarachnoid hemorrhage, let's talk more about the imaging features of RCVS. I guess we'll get into next. So, what do you see on imaging that may distinguish one from the other?
So there are imaging features associated with the vasculopathy itself, but then also of the brain. So both hemorrhagic and ischemic strokes are more common in primary CNS angiitis than in RCVS. However, within the hemorrhage group, subarachnoid hemorrhage is actually more common in RCVS than primary CNS angiitis. Some other brain imaging characteristics that might help differentiate the two are enhancing lesions or deep T2 hyperintense lesions are more common with primary CNS angiitis.
In contrast, parenchymal imaging of patients with RCVS is more likely to be normal than abnormal.
Then kind of moving on to vessel abnormalities, if there's cervical artery disease, specifically dissection, that almost entirely excludes primary CNS angiitis, and you think more about RCVS.
Primary angiitis, on the contrary, is traditionally considered one of the small vessel vasculitides.
More classically, a medium and small vessel vasculopathy.
Although, if only to confuse you, primary angiitis can affect the larger vessels as well, which is why ICA involvement is counted against the diagnosis being RCVS in that RCVS2 score.
Also, the features of the vasculopathy itself can help differentiate. So the classic picture for RCVS is a smooth tapering vessel with then more distal vessels being dilated, this sausage on a string appearance. Whereas in primary CNS vasculitis, it's much more dramatic vessel abnormalities.
Then there's also some pretty interesting data that's emerging on vessel wall imaging that can be used to distinguish these two conditions. The thought here is that with gadolinium enhancement of the vessel walls themselves, this would indicate inflammation of the vessel, like we would see in primary angiitis or a secondary vasculitis, whereas a lack of enhancement is more common in RCVS.
There are some studies to suggest that the type of enhancement, whether it be circumferential in the case of a vasculitis or eccentric in the case of atherosclerotic vasculopathy, can be helpful in differentiating between the two.
Which makes intuitive sense because you'd think that atherosclerosis is accentuated by an impairment of laminar flow, and it occurs more often at vessel turns, whereas inflammation of the vessel wall is more of a diffuse process, affecting an entire segment. But vessel wall imaging is still in its clinical infancy.
Unfortunately, there haven't been too many large studies that have clearly shown a benefit of these imaging techniques. So hopefully in the future, they'll become more helpful.
The vessel imaging may even be normal in RCVS.
In one study, 20% of patients on a presentation who got an MRA did not have any vessel abnormalities. And another study, 10% of patients that had vessel imaging and transcranial Doppler imaging did not have any abnormalities who were ultimately diagnosed with RCVS.
Angiographic imaging for primary angiitis of the CNS is also imperfect, studies suggesting it may only be 50 to 90% sensitive for detecting angiitis.
So in someone where you have a high suspicion, it's worth it to image the vessels again in 3 to 5 days.
Really just for RCVS?
Because some patients have this kind of delayed vasculopathy who have RCVS.
So that about sums up the imaging features you might use to differentiate RCVS from primary angiitis of the central nervous system. More infarcts and more subcortical white matter changes in primary angiitis, more subarachnoid hemorrhage in RCVS. Luminal irregularities are common to both, but sometimes the multifocal stenosis may lag the symptom onset in RCVS. ICA involvement, again, much less common in RCVS, and it's a component of the RCVS-2 score. But what about the other diagnostic testing that you could use to lean towards one diagnosis or the other? Dr. Thon and I talk next about the utility of a lumbar puncture.
Typically, the CSF profile in primary CNS vasculitis is actually just an elevated protein, which can be present in many other conditions, and especially like benign conditions as well. Only about a third of patients actually have pleocytosis in the CSF.
Again, we're talking about primary angiitis here. In RCVS, the CSF is typically normal or it's nearly normal. But if the CSF and the vessel imaging or clinical history aren't enough to cinch the diagnosis, more invasive testing may be necessary.
So often these patients where you're suspicious of primary CNS vasculitis undergo brain biopsy.
And what do you see on the brain biopsy?
So on brain biopsy, oftentimes you can actually see normal findings. And that can happen if you either miss the area of involvement. And actually that too, there's kind of, I learned this rule of thirds. So only about a third of patients who get brain biopsy who have primary CNS vasculitis, it'll actually show findings consistent with it.
That may be kind of surprising to hear, maybe even dissatisfying, but it highlights how multifocal the disease can be. And I don't think it should discourage a provider from recommending a brain biopsy. Treatment of CNS angiitis involves months and months of immunosuppression that's definitely not without risk. Furthermore, we have tons of data indicating that patients with suspected primary angiitis who undergo brain biopsy will actually have meaningful changes to their own treatment plan. Often, we get another diagnosis that isn't primary angiitis. CNS infections like HSV or JC virus with PML, or tumors like CNS lymphoma or intravascular lymphoma can all cause similar imaging findings. And case series have reported that you'll see this on brain biopsy in 20 to 40% of patients who were originally suspected of having primary angiitis.
But if you do get the area of involvement and it shows CNS vasculitis, typically it's the vessel wall inflammation of medium and small vessels, including the leptomeningeal and cortical arteries. And there's actually 3 different types of histopathological findings in primary CNS angiitis. The most common type is granulomatous angiitis, where you actually see granulomas. And the 2 other types are a necrotizing variant and then a purely lymphocytic variant.
The pathologist might also report nonspecific findings, like fibrinoid necrosis, as you might see with polyarteritis nodosa, or multifocal thromboses without apparent inflammation, and neointimal proliferation, or signs of vessel healing.
Yeah, there can be nonspecific findings, especially if you're actually not sampling an area that's involved, but also there can be associated perivascular inflammation. And if you just see that, it can be a little bit tricky to figure out whether this is actually angiitis of inflammation in the vessel walls, or if you're seeing some kind of paraphenomenon that's not related.
But if you're not going down the biopsy route, or the patient declines, or you have a low suspicion that it's primary angiitis, maybe you could just give it a minute.
Oftentimes, actually, the tincture of time is the most helpful. In RCVS, you'd expect a reversal of the vasculopathy, which is suggested in the name. And typically, you see that over the course of 3 months. So imaging again at that time period, you'd expect to see a reversal of some of these features. Whereas if it was atherosclerotic disease, you wouldn't see a reversal of the atherosclerotic plaque, And so that can be helpful in differentiating between them. In CNS angiitis, you could actually see progression of the vascular abnormalities, recurrent strokes, recurrent bleeds. So that would definitely not be typical of RCVS.
In the meantime, while you're waiting for that follow-up scan to see if those vessel irregularities normalized with discontinuation of the triptan, or if there are new strokes, most clinicians will just treat empirically. So how do you manage these patients?
So with RCVS, unfortunately, there haven't been any large randomized trials looking at treatment. Most of the evidence is based on case series, case reports, and expert opinion. I would say a standard treatment regimen is using a calcium channel blocker, which actually may not have any effect on the vasculopathy itself, but may help the headaches. And in my clinical experience, magnesium is particularly effective for headaches. Where I did residency, we even would oftentimes put these patients on a magnesium drip, raise their magnesium above 3 or 4, and we saw great results in terms of headache resolution.
Also, just to be clear, we always recommend avoidance of whatever that initial trigger was. If it was related to Robitussin or triptans, stop the Robitussin or triptans. But that's easier said than done in some cases. If the RCVS was only attributed to pregnancy or the purpurium, or if it was related to sexual intercourse, are you really going to recommend your patient avoid these experiences? Probably not. For most people, though, nimodipine or diltiazem are often sufficient.
So typically keep them on it until getting repeat imaging in about 3 months. And then if that's either stable, which you'd expect, or has resolved, then you can discontinue at that point.
And then, getting back to primary angiitis, the treatment is entirely different.
Entirely different. And that's why it's so important to have a broader differential when you see a patient with thunderclap headache or other findings suggestive of RCVS, because the treatment is completely different. It's important to diagnose patients with primary CNS vasculitis because there are treatments that can be used. So actually, the early studies looking at RCVS and steroid use actually showed a benefit. And actually, that was probably because those patients were misdiagnosed and had primary CNS angiitis. Later studies showed that steroids can actually have a potentially deleterious effect in patients with RCVS. So that brings us to primary CNS angiitis. How do you treat it? Immunotherapy. The standard treatment is steroids plus or minus cyclophosphamide. I favor using cyclophosphamide, particularly if there's a severe case of primary CNS angiitis. More recent studies have shown benefit in medications like rituximab,
the monoclonal CD20 antibody used for a wide spectrum of autoimmune neurologic diseases,
Cellcept,
or mycophenolate mofetil, used often in solid organ transplant to prevent rejection.
And then there's a question of how long to treat. So that is not fully clear.
Yeah. It seems like it's a long time.
Well, actually, maybe not. So treatment regimens vary from 6 months to 1 year. To where I did my immunology fellowship, we would typically treat for 2 years with immunotherapy and then try to taper off.
And you're talking about like relatively high doses of prednisone, like 1 milligram per kilogram per day kind of thing?
Yeah, absolutely. And not necessarily for the entire course. So definitely up front. But then once you get people on steroid-sparing agents, then you can start to taper that down.
What if somebody comes in and they've had recurrent strokes with CNS angiitis? Like, when do you say, okay, we've been on prednisone, or you've been on Cellcept, or you've been on rituximab? How do you escalate therapy, or do you consider an alternative diagnosis?
Sure. I think if someone's not responding to therapy, then you of course want to readdress whether you have the right diagnosis. And especially, when you're using heavy duty immunotherapies, you want to make sure that you're not making things worse in the setting of an infection. But, I've seen a number of cases that were refractory to initial immunotherapy and then responded nicely after adding on other things. One patient in particular I'm thinking of was initially on high-dose steroids, cyclophosphamide, and then ultimately only stabilized once rituximab was added, and even Cellcept were able to wean off the cyclophosphamide, and he'd been stable for a year. So although, yes, it can be a monophasic course, there have been a number of cases of patients who have recurrent disease. And again, it points to, with all these conditions, with RCVS, primary CNS vasculitis, it's actually probably not one thing. it's a spectrum of diseases that present in similar ways and respond to similar treatments.
Before we wrap up the show, we've really only summarized the key differences between RCVS and primary angiitis of the central nervous system. Honestly, because the two are so commonly considered together when you encounter a patient who has headaches and vessel irregularities. But it's equally important not to miss any other mimics of these conditions.
In RCVS, we've talked a lot about primary CNS vasculitis, but there are other pathologies that lead to a vasculopathy. So things like other autoimmune conditions, like rheumatologic disorders that can affect the systemic vasculature and also the cerebral vasculature.
These would be your giant cell arteritis, ANCA, or other antibody-associated vasculitis.
ANA or Sjogren's antibodies, because that can actually sometimes be associated with a large vessel vasculopathy.
Polyarteritis nodosa, Churg-Strauss.
And then infectious etiologies, things like syphilis.
Or HIV.
VZV.
A lot of fungi can also cause a vasculitis, in particular aspergillus. Sometimes we see certain cancers with this pattern.
Intravascular lymphoma.
And this other rare condition called lymphomatoid granulomatosis.
And then there is the much more common vasculopathy that's due to atherosclerosis,
which is what it ends up being 90% of the time. So the take-home point here is that you don't always know if it's going to be atherosclerotic disease or not, if the headaches are just something benign, as part of your patient's stroke symptoms. And I harp on this all the time on rounds because patients with strokes due to intracranial atherosclerotic disease, they are at an extremely high risk of a recurrent stroke, no matter what we do. In Sampras, the stenting versus medical management trial for intracranial athero, with the most aggressive therapy we had to offer, 15% of patients had a second stroke within 90 days. Compare that to the 3% risk of 90-day stroke in AFib, or 1 to 2% risk of strokes due to any other cause. 15% with intracranial athero. In patients with vasculitis, we also worry about rapid progression of infarcts or neurologic deterioration, because this also happens for them. But it doesn't mean that your patient with vessel irregularities and a hemoglobin A1C of 9% doesn't just have athero. The bottom line here is that if you suspect CNS vasculitis, or you suspect RCVS, consider taking those extra steps to confirm your diagnosis. Repeat the vessel imaging to see if the vessel irregularities are changing. Maybe they're rapidly improving, or they're even worsening, as you might see with RCVS. Or if they're identical months later, you might see this with athero. Consider sampling the CSF if you suspect angiitis. It's definitely safer than a brain biopsy. But don't take brain biopsy off the table. Before you initiate months or years of prednisone and rituximab or mycophenolate, you'll probably want to feel reassured that you're committing this patient to serious immunosuppression because you are wholly convinced that it's not something infectious and it's not just atherosclerotic plaque. And that's all we have to say about that.
Thanks a lot, Jim. That was a lot of fun.
Cool, man. The BrainWaves podcast is produced at Studio 3 in Philadelphia, Pennsylvania. Jim Siegler, senior producer. The episode this week was also produced by Dr. Jesse Tone. Music for our program was courtesy of Nuno Adelaida, Peter Rudinko on the piano, Squire Tuck on the guitar, Swelling, and Uncanny. Sound effects by Mike Koenig and Daniel Simeone. For more information, take a look at the show notes in each week's program for references to the peer-reviewed literature. Please follow us on Twitter or Facebook at BrainWaves Audio, or email us at bweditorialboard@gmail.com. And we'd love to hear from you if you've got any thoughts about today's program or anything else that we've put out in the past. I'm Jim Siegler for BrainWaves. Thanks for listening.